So I'm going to go a little bit into the basics of image acquisition and how you acquire some images to help you again so you can understand this better, and as you're helping students you can help troubleshoot them and help them improve what they're doing. So the number one thing that you need to know, number one rule, the most important thing is the hands need to be on the patient. Just like you teach students to stabilize their hands on the side of the patient's head as they're putting the otoscope in their ear, same thing with this. Their hand needs to be stabilized on the patient with the probe so that the probe is almost an extension of their arm. And I often will say, hold it like it's a pencil. You almost pretend that the probe is a pencil in your hand, you're drawing pictures on your patient, okay? So just a couple of things about acquiring images. Make sure you choose the correct probe. Get the patient in the best position possible. So there are some times where a minor change in position will make a big difference in your image. Make sure you use plenty of gel. Don't be afraid of it. We're going to talk about the 4 kind of movements that you'll do with the ultrasound probe when it's in your hand. When you're working on an image and you're trying to adjust things, you want to try to do one single movement at a time until your image is fixed. And if that movement doesn't work, go back and then try a different movement. Use acoustic windows where it's possible, and in many cases the respiratory cycle can help you as well. These are just some images showing, this is kind of the sweeping movement that I'll get into, and this is showing you how you'd like to keep your ultrasound beam as perpendicular as possible to your structure of interest. So as much as possible the ultrasound energy strikes the structure like the kidney and then comes straight back to your ultrasound probe. The more off axis you are, the more energy is lost and you'll lose some of the quality of your image. And then the most important thing with getting good at ultrasound is just practice. I often say to students and our residents that this is like a video game. You know, when you got Super Mario Brothers for the first time, if you're old like me, you know, you might have picked it up and decided, okay, what's the A button do? What's the B button do? And then you put the instructions down and you played it. That's how you got good at it. That's how you get good at this. You can listen to me talk once, but when you're having trouble and need to get better, the best thing you can do is practice. And then maybe you listen to little tidbits here and there, but practicing and doing this is what makes you good at it. So just some of the hand skills and how to manipulate the probe. Like I said, you want to hold this thing like it's a pencil and you're drawing pictures on the patient's body. Your hands need to be on the patient, touching the patient the whole time. And then there's 4 main movements that you're going to do with the probe. And so it helps to kind of think about them as you're doing them and pick one to do at a time as you change things. And those movements, I'll show you examples, are sweep, rock, rotate, and slide. And just in case I haven't said this yet, because sometimes I forget, hands got to be on the patient. So if you're looking at a student and you're trying to help them, look at how they're holding it. If their hand isn't touching the patient or they're holding it some funny, wonky way, tell them to fix that. And a lot of times I'll find that holding the probe right will almost instantly improve the quality of their image. So the 4 cardinal movements, so this is a sweeping movement. So here what we're doing is we're moving perpendicular to the axis of the ultrasound beam. So you can imagine the ultrasound beam is like a fan coming down off of the probe, and we're sweeping the beam towards the head, towards the feet, towards the head, towards the feet. And that's our sweeping or fanning movement. Now we're doing the rocking movement, which is moving parallel to the axis of the ultrasound beam. So now we're rocking the beam towards the head, towards the feet. Now we're rocking the beam towards the patient's right, towards the left, towards the right, and then it could have gone back towards the left. So that's the rocking movement. And then next is rotate. So generally you can think of their head as noon or 12 o'clock, and we can rotate clockwise or counterclockwise. Hopefully that makes sense. There we go, counterclockwise, and then we'll go back up to clockwise. Okay, and then last movement really is the slide movement, so we can slide towards their head, slide to their left, slide to their shoulder. We're essentially moving the probe in different areas without losing contact with the skin. So just a little bit about basic ultrasound views. Hopefully those probe manipulation movements were helpful to you. A lot of these are easy, but then a couple of them get a little bit harder, so I'll go over these. So most of the time we're going to do sagittal or longitudinal views, where we have the indicator towards the patient's head. And when we have the indicator towards the patient's head, we're slicing them sagittally, sometimes coronally. But generally that will mean the head is on this side of the screen and their feet are on this side. If we're in the front of their body, then this is going to be anterior and posterior, But if we're on the side of the body, then this might be lateral and medial, or if we're on their back, then this could be posterior and this could be anterior. But most of the time, we're probably on the front of their body, where this is going to be anterior, this is going to be posterior. Head, feet. And then another kind of standard view that we'll do commonly is a transverse view or an axial view, where the indicator is directed towards the patient's right. Indicator would be here on the screen. And so this is kind of like just a slice out of a CAT scan or an axial cut, where this is the patient's right side, this is their left side, this is anterior, and this is posterior, okay? And those are our views that we're going to do very commonly. However, realize that some of the structures that we look at don't lie straight up and down in your body or straight transverse in your body. So we'll commonly, and this is one of the advantages of ultrasound, is that we can take different slices. However we turn the transducer is how we're slicing the body. And so we'll often refer to structures in their long axis and their short axis. And common ones you'll think of are the gallbladder and the heart have long axis and short axis orientations. So you can imagine the heart kind of lies diagonally in the chest. Its long axis runs in this direction. Its short axis runs in this direction. Or sometimes I'll compare this to an eggplant. Whereas if you slice it longitudinally, it looks a little more hourglass-like. And if you slice it transverse or in its short axis, it should look like circles. So here's our heart. We've sliced it along its long axis, and we can see the length here of the left ventricle. And here along its short axis, we see the left ventricle appears more like a circle. Okay, so we'll often slice structures that give us images in orientation of long and short axis. And just another example here, we're looking at the bicipital tendon and the bicipital groove. This is the bicipital tendon in its short axis. It looks roughly circular or moon-shaped. And here, as we rotate the indicator towards the patient's head, we'll see it in its long axis, where it looks kind of long. There's our bicipital tendon. Now, as far as applications, like I said, you can ultrasound every organ in the body pretty much. It applies to most organ systems, and the more we do this, the more research that comes out. We find that with good technique, we're often more accurate with this modality than we are with a lot of our traditional x-rays, and certainly more accurate than we are with a lot of our physical exam findings. And then, in addition to just straight organ systems, we have specific clinical scenarios, like for resuscitation, fast exams, or in patients in shock, or evaluating the physiology of critical care patients, and of course procedural guidance. So we'll get into that as we go through different applications. So for this next little section here, I wanted to go into a little bit about some of the things. I know that some of you are looking at this and saying, wow, this is all brand new to me. I've never done anything like this before. How can I do this? And how can I even be the kind of quote-unquote expert teaching these students as they're coming through rotating on my service? And so I want to try to address some of those and talk about some ways that even though you might feel novice, how you can help students and you can help them improve what they do with ultrasound. So again, the issues. I'm a novice. How can I do this? We'll talk about that. What if I miss stuff? Or what if I overcall things or see things that aren't there? These are common concerns, and these will come up. And I'm going to talk about how we can minimize some of these problems and how, even as a novice, you can help. Trust me, like I said, being a novice teaching residents in the past, I know that this can be intimidating and makes you a little bit afraid, but you can do this, and we should embrace this and be proud that we're doing this, looking to the future, and being leaders in this area instead of kind of following everybody else. So here is a big answer to a lot of that, is the way that we're going to have our students select patients. And this is how I suggest, if you're interested in incorporating more ultrasound into your practice, I suggest you do the same thing. This is the majority of how a lot of emergency physicians, including myself, learned how to do ultrasound before it was very standard teaching in residencies. So choose your patients carefully. Choose patients that have just had recent imaging. It doesn't always have to be an ultrasound, because sometimes there are findings you can see on other imaging modalities like CT scan that you can also look at with ultrasound. A good example is kidneys for hydronephrosis. They might have had a CAT scan showing no hydronephrosis, and you can look at their kidneys with ultrasound and confirm, hey, I don't see hydronephrosis. Or a patient that has scheduled imaging. So you have them admitted for their shortness of breath, and they're going to get an echo tomorrow. You can have your student do a limited bedside echocardiogram, and they compare that to the study they're going to get the next day. That way you haven't missed anything. You're not worried. You don't have to worry about overcalling anything because you have a reference standard available, either already done or that's about to happen, that you know it's going to give you the answers you need and going to confirm or deny what you think you might have seen on the bedside ultrasound. Now, in some cases, you don't necessarily need imaging. There might be other clinical follow-up that can confirm or deny your findings for you, okay? So you have a patient with an abscess on their forearm, and you've decided, hey, this is an abscess, I'm going to IND it. Well, before you do that, take a look at it with ultrasound, put color on it, make sure there's not a blood vessel. Then after you IND it and you get a bunch of pus out, you can say, hey, the findings on my ultrasound were correct. I saw what looked like a fluid collection. It didn't have blood flow in it. It wasn't a blood vessel that I cut into. There's clinical follow-up where imaging isn't necessarily needed. Or a patient that has known ascites that comes in all the time and you drain their ascites. Take a look at that with ultrasound beforehand, and you can look at it and say, hey, this patient has ascites. Here's what it looks like. Then you tap it, you get fluid out. You have confirmed your findings on ultrasound. So most of the time it's going to be imaging, but sometimes there are other clinical things that can serve as your follow-up for your ultrasound procedure in your teaching scenarios. So with a standard reference available, you can help eliminate misses and overcalls, and then the more you do this in your practice, eventually you can incorporate into your practice where you don't always need recent or follow-up imaging. But as you're getting started and as we're teaching students, this is the approach to take. Now, not necessarily for the students, but if you're asking yourself, well, what if I do want to start incorporating this into my practice, but I'm not quite ready yet? How can I do this? Well, that's the model, is ultrasound patients that have had recent or have scheduled imaging so you can follow them up, or they have the appropriate clinical follow-up. And then what's generally recommended, not a greatly scientific number, is at least 25 studies per each application you want to incorporate into your practice. So say you want to start doing DVT ultrasounds in your practice. What you should do is patients who are going to get a DVT ultrasound in the vascular lab, when you see them in your practice, either before or after, do your own DVT ultrasound, and then compare that to what you saw in the vascular lab, troubleshoot, and try to match the results of what they get in the vascular lab. After you've done that 25 times, then you should be about ready to incorporate this into your practice. Or you can do this with oversight from someone else, either someone in the vascular lab, someone else who's already an ultrasound expert can be your reference standard if you don't have vascular studies all the time, but 25 quote-unquote proctored studies roughly, and then you should be able to incorporate this in your practice. And then anybody who's doing ultrasound in their practice should have some system in place for ongoing review and QA. And just to address, everybody worries about this. This is something that comes up frequently, is what if I miss stuff, or what if I overcall stuff? And what I usually say to that is every diagnostic modality in the world is prone to misses and overcalls, right? History and physical, we miss stuff or we overcall stuff. On EKG, sometimes we activate the cath lab and turns out they don't have disease at all. Every other imaging modality in the world has this. Now, it doesn't mean we should just blow it off and say, oh, whoops, I missed it or overcalled it, no big deal. We don't want that to happen, but it's going to happen, and it's okay if it happens. If we put systems in place, we learn this properly, we do follow-up studies initially until we are able to incorporate into our practice, and then just like everything else we do in medicine, where we do M&Ms, peer review, and we have standard QI and practice improvement, we can improve this. And again, just like everything else we do in medicine, nothing is perfect. Ultrasound is no different. So now back in, I kind of get off track a little bit there talking about incorporating into your own practice. But how can you help the students right now, even as a novice? So let's talk about that a little bit. And just I want to point out that we're training future physicians. We're not training them necessarily to do things that you're doing right now in your practice. We're training them to do practice in the modern era and as healthcare evolves and as ultrasound becomes a standard toolkit in all of their tool bags. So think about that as we're doing this, that we're investing not just in now, but we're hoping to see these dividends 20 years from now when we are patients of all these students. And I think it's really important to embrace the idea of co-learning, which is good for a couple of reasons. If you model to students that you are a lifelong learner and that you're willing to learn new things and not always be the expert, then that shows them how important it is to be a lifelong learner. and always look for ways to incorporate new, important, and useful things to their practice. And so I think that's important, and I think students really respond to that. And I'm learning new stuff every day, and students teach me things all the time, and I think it's fun, it makes our job more rewarding, and I think the students, again, like I said, I think they respond to that. So hopefully you can enjoy that like I do. Now, specifically, what do these students need? Now, remember, these students have had ultrasound in their gross anatomy. They've had ultrasound information on pathology incorporated into their second-year curriculum. So they know how to use the machine reasonably well. They know how to recognize normal anatomy. They know some of the key pathology that they might be looking for. But what they don't know is necessarily how to incorporate it clinically. You guys are the expert clinicians that can help them figure out how to use this info clinically and incorporate it into their practice. And even though they know how to do this, basically they still need more practice and more scans or ultrasounds under their belt to just get better with acquiring images more consistently. And I think sometimes the most effective way you can teach a student is to just say, hey, there's a guy who I know has an ejection fraction of 25. Why don't you go take a look at his heart? And just doing that and getting them to go do it in practice is a huge benefit to their training and helping them improve their ultrasound skills. And if you just do that, you have done those students a service. Now, how can you help them with acquiring images, especially when you feel like you're probably a novice and maybe you're not that great at acquiring images yet yourself? So some of the easiest things you can do, you can always take a look and check the basic things. And anybody can do this. Do they have the right probe on? Do they have the right setting? Is their depth and their gain about where it should be to make the images look right? After you check those things, you can just check, do they have the probe in about the right place on the patient? Are they holding it right? Are they holding it like a pencil? Are they anchored on the patient with their hands down and really stabilized on the patient? And if those things are all right, then you can work on try to sweep towards their head, or try to sweep anteriorly, try to sweep posteriorly. If that doesn't work, go back to your starting spot and try to rock towards their head, rock towards their feet, or rotate a little bit, slide a little bit. You can try those 4 movements to help them optimize their image. And a lot of times you can do all of this without even having to touch the probe, and you don't have to even be that great at acquiring the images yourself necessarily, but you can help guide them a little bit. Now, they also need teaching on how to clinically integrate this information. So it's very important that they understand the concept of answering some basic yes or no questions with their ultrasound machines. They have to know what those questions are ahead of time and know what they're going to do with those answers when they get them. And we'll get into those a lot more specifically as we talk about different applications. But what they're going to be able to do with these is sometimes they'll be able to make a diagnosis right away, like, wow, gallstones, there's a diagnosis. Or no gallstones, but now my differential's altered because I can move biliary colic way down on my list. So it's important to realize that a lot of times we may not be making a diagnosis, but we're altering our differential diagnosis. And I think that's a good practice anyway, to help our students always be thinking about a differential and how to modify it up or down, and ultrasound is a great tool to teach them that. And so with that, a lot of times ultrasound you can show them how they can decrease other tests, or sometimes it's going to suggest a different test that maybe you weren't thinking about. And then later we'll get into procedural guidance and physiologic assessment, but we'll get into that when we get into specific applications. But these are all things that without even knowing how to scan that well, you can help teach students these things right now. So some of the examples we'll get into are skin infections, complicated UTIs, and acute kidney injuries, cardiovascular symptoms, abdominal pain, leg pain. These are all areas where I do this every day, where ultrasound helps me in all these scenarios every single day, make a diagnosis, change my differential, guide a procedure, or suggest something I wasn't thinking about before. And like I said, we get into as we get specific applications, hopefully we'll shed more light on a lot of these. Just some of the examples of yes or no questions. Is there a fluid collection? Yes or no. Is there hydronephrosis? Yes or no. Hydronephrosis in the febrile UTI patient means a longer course of antibiotics, maybe an admission versus going home, more workup versus less workup. In the leg veins, do the veins compress? If they compress, probably not a DVT. Is the left ventricular function poor or not? Is there a pericardial effusion? Is the IVC flat or collapsing? These are all the questions, but by themselves they don't mean anything until you incorporate that clinically and know what to do with them. So again, like I said, as we get into applications, hopefully seeing how we do these and how we incorporate them clinically will help you out a lot. So that's about all the info I got. I want to just quickly summarize a few things and a few key points. So way back to the beginning, hopefully you'll believe me, and if you don't believe me now, hopefully in a year or two you will believe me, that ultrasound is an awesome tool that can help you be a better doctor. And it's got wide clinical application. It applies to every organ system. I won't say any more about it. So if you ignore a lot of the buttons and pay attention to these key things, the on button, get the right probe and the right preset, know where your set key is, it's your master key, and then you can adjust two things, the depth and the gain. You will be good to go for like 90% of the ultrasound that you're going to do, okay? So it doesn't have to be that intimidating. Remember, with your transducers, high frequency are for superficial things and low frequency are for deeper things. Remember, on the screen, things that are described as hyperechoic or echogenic appear bright white, and things that are described as hypoechoic look somewhere closer to black, okay? Hand skills, you remember that the residents or students should have their hand on the patient. They should hold it like it's a pencil. And remember those four primary movements, sweep, rock, rotate, and slide. And encourage your students to have good, tight hand control. And hopefully at the beginning at least they're getting forearm and hand cramps if they're doing it right. And hopefully after seeing this and talking about this and doing it a little bit when we do hands-on sessions, you'll see that this is doable. Even with some basic training, you can gain things that will help you hopefully within a couple of days. That even as a novice, you can help these students get practice in acquiring images just by encouraging them to do it. You don't even need to be in the room a lot of the times. If you just say, hey, I think this guy might have gallstones, why don't you go take a look? We're going to have an ultrasound in the morning anyway. See what you find. And then again, you as the clinician, hopefully use your clinical knowledge and help them learn how to use this information clinically and integrate it into their plan of care to hopefully decrease other tests, make diagnoses, or change their differential diagnoses. Stick to yes or no questions. And remember, at least at this stage of the game, we're going to be looking at patients that have a reference standard already done or to be done very shortly, so that we don't have to worry so much about misses and overcalls right now, okay? So hopefully that'll, again, allay some of the fears or concerns that you might have about that. I think that's about everything. I look forward to working with you all. I think this is going to be fun. And, I'll see you soon. Thanks a lot.